Good afternoon, everybody. My name is Keryln Carville, and I'm here with Emily Haesler and with Pam Mitchell. And it is our privilege today to present to you the International Guideline for Prevention and Treatment of Pressure Ulcers Injuries. This webinar is made possible because of the generous support from the College of Nursing, Australian College of Nursing, and Arjo. And we're very grateful for the support and allowing us to share this webinar with you. Let us begin by introducing the new guideline. So the 2019 guideline incorporates new evidence and builds upon the research that was appraised and summarised in the earlier 2014 guideline editions and the 2009 guideline. That is, the evidence that remains still relevant. The purpose and the scope. The purpose is to provide evidence-based recommendations for the prevention and treatment of pressure injuries that can be used by health professionals, patient consumers and informal caregivers throughout the world. It applies to all clinical settings and to all populations. And it is my pleasure to introduce to you the Guideline Governance Group. It's represented by 3 groups that were partnered within this development. We have the Pan-Pacific Pressure Injury Alliance. We have Pam Mitchell from representing the New Zealand Wound Care Society, Susan Lee, who represents the Hong Kong ET Nurses Association, and Yi Chang, who represents the Wound Healing Society of Singapore, and myself, and I represent Wounds Australia. The NPIAP, the National Pressure Injury Advisory Panel, it was chaired by Dr. Janet Cardigan. The other 3 members were Dr. Mary Litchfield, Dr. Dan Berkowitz and Dr. Joyce Pittman. The European Pressure Ulcer Advisory Panel was chaired by Dr. Jan Kottner from Germany, Professor Zena Moore from Ireland, Professor Dominique Seguado-Rizel from France, and Professor Dr. Katrine Balzer from Germany. What was unique within this guideline was that along with the 3 partnering organisations, we had 14 associate partners, and they came from countries that are listed here, such as Brazil, Canada, China, Indonesia, Japan, Korea, Malaysia, Philippines, Saudi Arabia, Taiwan, Thailand, and the World Council of Enterostomatology Therapy Nurses also represented a large number of nurses from countries where they had small memberships that didn't comprise an associate partner. So this is an exciting event because it meant that we could also have access to evidence that was produced in different languages, and providing there were more than 2 people or 2 people who could translate that evidence and it met the criteria for inclusion, it could also be added to the guideline. So it's now my pleasure to introduce Dr. Emily Haesler, who is going to outline the methodology for us. Thank you, Emily.
So I'm going to talk about the changes in the methodology for the 2019 edition, and there was an extensive review of the methodology due to advances in the guideline methodology over previous 5 years. In brief, some of the major changes that you'll see in this edition are a clearer distinction between evidence-based recommendations and statements based on expert opinion, introduction of implementation considerations, and these 2 changes have led to an overall reduction in the number of recommendations from almost 600 in the 2014 guideline to only 115 in the 2019 edition. The 2019 edition also uses evidence to decision frameworks that I'll talk more about in a moment, but essentially these provide a more distinct connection between the evidence and the recommendations. There's been an update in the evidence ranking scales used to rank individual studies and the strength of the body of evidence in this guideline, and there's been an increase in the involvement of patients and informal caregivers, which I'll discuss in more detail. So A brief overview of the methods. The methodology was reviewed to be consistent with other international standards, and it was published on our website from November 2017. Then the methodology was published in a peer-reviewed journal earlier this year. The literature search for the new guideline extends from July 2013, which was the cut-off date for the 2014 guideline, and it extends to August 2018, so essentially covering the full interim period between guidelines. It was in the 2019 guideline, there's an expanded list of specific clinical questions. There's around 70 clinical questions, and these are presented in each chapter. These clinical questions guided the evidence search and the development of the recommendations. The evidence ranking systems have been adjusted with revised levels and strengths of evidence. There's new good practice statements introduced, and the evidence to decision frameworks that I mentioned were used to clearly present the evidence related to interventions. The frameworks clearly summarise the evidence findings, potential benefits and harms of an intervention, feasibility, acceptability and priority of outcomes for patients, and cost effectiveness. And they more explicitly demonstrate the link between the evidence and the final recommendations that are made in the guideline. These frameworks were presented during stakeholder feedback, and they'll be available on our website in early 2020. Implementation considerations have been introduced, and these essentially practice points which provide additional guidance to support the recommendations. There was increased transparency in the strength of recommendations assignment, supported by the clear ratings from the evidence to decision framework. And conflict of interest management was updated. Anybody who had declared a conflict of interest of moderate or high level was excluded from reviewing papers, being involved in discussions about recommendations and in voting in the final strength of recommendations. The evidence ranking systems used in the guideline. We have levels of evidence which are assigned to individual studies. These are based on the study designs, and they're included throughout the guideline in italic. The strength of evidence is assigned to the body of evidence supporting each recommendation, and it's based on the level of evidence, the quality of that evidence, the volume and the consistency of the studies. This strength of evidence used in this guideline has been revised somewhat from the 2014 guideline, and it's based on both the NHMRC strengths of evidence and the Joanna Briggs Institute strengths of evidence. The strengths of recommendation are the extent to which one can be confident that adhering to a recommendation will do more harm or good, more good than harm. It's based on the strength of the body of the evidence, the clinical importance, the potential to improve patient outcomes, feasibility and acceptability, cost effectiveness, and health professionals can use these strengths of recommendation to prioritise interventions for individual patients. So the strengths of recommendation in this guideline are the same scale that was used in the 2014 guideline, but the symbols have been updated. And importantly, where the development team was uncertain about the likely benefits of an intervention, maybe if there was conflicting evidence or not a strong enough body of evidence, no specific recommendation was made. In this guideline, none of the recommendations were rated as probably don't do it or definitely don't do it. From all of this, there's 115 evidence-based recommendations in the guideline and 61 good practice statements. And these are statements that are not supported by a body of evidence, but that the guideline governance group felt was significant to clinical practice. The good practice statements cover areas of practice that are considered important, and they often cover areas where there is little research, and they often cover areas of common sense. It's most important to remember that recommendations and good practice statements are a general guide to appropriate clinical practice to be implemented by qualified health professionals, but it's subject to your clinical judgment and should be considered for each individual patient, considering the patient's preferences, the health professionals' abilities, the available resources, and the clinical setting. The guideline should be implemented in a culturally aware and respectful manner in accordance to the principles of protection, participation, and partnership. Finally, most recommendations are also supported by implementation considerations. These are identified in dot points underneath the recommendations and good practice statements, and they provide more information about where, when, how, and how often the interventions could be implemented. The guideline explicitly states the types of evidence each of these statements is based on. So aside from the guideline governance group introduced by Keryln, who else was involved? There was 176 international participants working on 28 small working groups. In each small working group, there was 6 to 8 participants with related expertise. These participants were screened, they were selected through a selection process, and they screened and appraised the evidence. They developed and reviewed evidence tables. They reviewed the evidence to decision frameworks, and they drafted recommendations. All of the small working group members were also eligible to vote for the strength of recommendations, which were voted on through a consensus process. There was significant stakeholder engagement for this guideline. Patient and public involvement is recognised as a requirement for high quality international clinical guidelines, and it's required by organisations such as the Institute of Medicine, the ECRI Institute, and other guideline development bodies, including the NHMRC and the National Institute for Health and Care Excellence in the UK. The purpose of patient and stakeholder involvement is to make guidelines more patient-centred and more trustworthy, and most importantly, it recognises that patients are experts in their own needs. For this guideline, there were over 1,200 invited stakeholders, and from these, almost 700 stakeholders provided comments that were reviewed by the development team and incorporated into the final guideline. For this guideline, there's a new focus on developing strategies to increase the direct voice of patients, which is an emerging area in international guideline development. The process used to do this was through an international patient and informal caregiver survey. It was web-based and it was available around the world. It was translated into 10 languages and available for participants to respond to for 6 months in 2018. And the survey focused on patient care priorities and information needs. This patient survey received ethics approval in Australia and was given waivers in the UK, the US and Japan. It was disseminated through promotion by health professionals, promotion at international conferences, promotion via social media, and through consumer organisations. So how was this information used in the guideline? First, the survey information informed the assignment of the strengths of recommendation. Every recommendation is given a strength, and the information provided by the patient survey informed the information on the evidence to decision frameworks about how acceptable a recommendation might be to a patient, whether the outcome of research was a priority for patients, and whether patients thought an intervention was feasible or not. The survey information also gave the development team some data on whether particular areas of care that focused on patients fed into recommendations. So some of the recommendations stemming directly from the data from the survey included to assess the health-related quality of life, knowledge and self-care skills of individuals with or at risk of pressure injuries to facilitate the development of a pressure injury plan and education plan. As we know, identifying areas of knowledge deficits and skills is the first step to providing patients with relevant information they need. and self-care skills. Another recommendation stemming directly from the patient survey was to provide pressure injury education, skills training and psychosocial support to individuals with or at risk of pressure injuries. And this was an evidence-based recommendation.
Excellent. Thank you.
I'm now going to hand over to Pam Mitchell, who will discuss key recommendations from the prevention part of the guideline.
Okay, so screening and risk assessment. Screening can be formal, or like tea, or it can be informal, like just checking whether the patient can mobilise or not. But it considers the main risk factors. And if a patient is deemed to have at risk with the screening tool, then a full risk assessment should be completed. The risk status should be discussed with the individual, and all prevention strategies also, so that when we implement them, we're implementing them with their goals in mind as well. Skin assessment is a really important part of risk assessment, and there have been lots of advancements in technology in this area, but not everyone has access to the devices and the measures such as thermography and subepidermal moisture devices. Our hands are our most important tools, and we can all feel changes in temperature, texture, and our eyes can tell us if there's a change in colour or skin tone. So it's really important to use the practical things as well. With the good practice statements associated with the risk assessment, when conducting the pressure injury risk assessment, it should be structured. It should include a comprehensive skin assessment and supplement the risk tools with additional risk factors. And it all should be interpreted using our clinical judgment. I think sometimes we don't always do that, and it's really important. The implementation considerations are a real addition to this guideline. And when we're using a risk assessment tool, we need to select one that's appropriate to our population. We don't want to rely just on the tool's total score, but we're also going to look at the subscale scores and the risk factors that are relevant to our patients, so that actually our risk-based planning is appropriate to each patient, and it's completely individualised. Also, with risk assessment, we need to reassess that risk at regular intervals, and that will depend on your setting. The population-specific risks that are identified in the guideline are grouped on these following slides. And so there's critical care setting, and within that, there's looking at the length of stay in ICU and mechanical ventilation, vasopressors, and the Apache 2 scores. With neonates and children, skin maturity and perfusion and oxygenation, and the medical devices that are used on young babies often have an effect on the skin. The illness and severity and the duration of the stay in critical care for these young ones has a significant risk to them. In operating room, we have a lot of time immobilised before, during and after surgery often, and the ASA scores are more frequently being used by the operating room. The community aged care and rehabilitation centre settings have there are relevant implementation considerations throughout the chapters on these. And with obesity, there is a number of recommendations, two of which are the bariatric pressure redistribution support cushions to make sure that we have the right size and the right type of cushion. that the bed surfaces are sufficiently wide to allow turning, and that we do the best for our patients so that they're not held in a very tight area in a small bed. So the most interesting and an extra thing that we had, in this guideline was the individuals in transit using the support surface during transit, and our ambulance and medics have been really good at instituting some of these into our transfer of patients so that our patients are safely transferred. The preventive skin care, implementing a skincare regime and keeping the skin clean and well hydrated, cleansing the skin promptly after episodes of incontinence, and avoiding alkaline soaps and cleansers, protecting the skin from moisture with a barrier product. And we all know these things, but it's really important to just be reminded that there's a high strength of evidence and a high strength of recommendation for them. The preventive skincare continues on looking at your high absorbency of incontinence products, and also at the soft silicone multi-layer foam dressings as prevention. Both of these should be used appropriately so that when they're full or wet or have excessive fluid in them, that they're changed regularly. With repositioning, all the individuals that are at risk require an individualised schedule for repositioning unless that's contraindicated. So it's really important that we continue that and we check their skin tolerance for how frequently that should be. It should be individualised. And there are other methods which not all of us have available to us, but the continuous bedside pressure mapping is a good visual cue to guide repositioning. When you implement the repositioning strategies, we need to promote an adherence to those repositioning regimes depending on the patient's tolerance. And we reposition individuals to relieve and redistribute pressure, but we do use manual handling techniques and equipment, and we must make sure that we use the right size equipment for the patients. So with hoists, that we have the right size sling, and that we use the right techniques when we're using sliding sheets and things like that, so we reduce friction and shear. The use of the 30-degree side lying position in preference to the 90-degree lying position still is a strength of evidence, has a strength of evidence of C, and is still encouraged. So repositioning prevention recommendations with increased strength of evidence in the 2019 guidelines, the use of repositioning on individualised need. The head of the bed as flat as possible. Previously we'd had it at 30 degrees. Promote limited seating out of bed for individuals with existing pressure injuries, and consider using textiles with low friction coefficients for individuals who with or at risk of pressure injuries. The repositioning of seated individuals is really important, and teaching them how to change their own position is important. Their seating needs to be correct for them and fitted for them. In operating room, there's a lot of new diagrams on repositioning patients and their pressure points within an operating theatre, and I think this will be very useful for our care. Nutrition is much the same as what it was previously, the screening and assessing of the nutritional status and the pressure injury prevention focus on individual with protein intake. Keryln's going to talk about that a little bit later as well for treatment. So with preventing heel and pressure injuries, it's really important to assess the vascular and the perfusion status of the lower limbs, the heels and the feet, when we're doing our skin and tissue assessment and as part of the risk assessment. We need to offload those heels and distribute the weight along the leg, along the calf, so that we're not placing pressure on the Achilles tendon or the popliteal vein. It's really also recommended to use prophylactic dressing as an adjunct to heel offloading. And we need to ensure that we use all the strategies to prevent these heel pressure injuries. Medical device related pressure injuries appear to be more common now, and we have a few recommendations within that. We need to reduce the risk of the medical devices related to pressure injuries and review whether we need to actually protect the skin underneath, and we need to check that skin daily at least, or more frequently if the skin is at high risk. We need to regularly monitor the devices and assess the individual for their self to see how comfortable they are. We need to use prophylactic dressings to reduce that risk of the pressure from the medical devices. I'm now going to hand over to Professor Keryln Carville for the key messages.
Thank you, Pam. Thank you. The evidence for assessment and treatment as outlined in the guideline begins really with the need to assess and manage pain. And so we need to conduct a comprehensive pain assessment for individuals with a pressure injury. That ranks as a B1 or definitely do it in regard to strength of recommendation. Use non-pharmacological pain management strategies as a first-line strategy and adjuvant therapy to reduce pain associated with pressure injuries. Use repositioning techniques and equipment with consideration to preventing and managing pressure injury pain. Use the principles of moist wound healing to reduce pressure injury pain rather. To consider applying a topical opioid to manage wound-related pressure injury pain if required and when there are no contraindications. And that ranked as strength of evidence B1, but with no specific recommendation to practice. And 11.6 outlines the need to administer analgesia regularly to control pressure injury pain, and that's a good practice statement. Pam's already talked about the need for good nutrition in the preventative stage, but should a pressure injury occur, then we need to be mindful that energy intake energy intake increases, but the recommendation for this is unchanged as compared to the 2014 document. It remains a B1 strength of evidence and a do-it strength of recommendation. Protein intake recommendation is also unchanged in this edition, and the need to consider high energy, high protein supplements containing arginine, zinc and antioxidants still remain B1 evidence with a strength of recommendation. Definitely do it. When it comes to good assessment, that assessment includes assessment of the individual, assessment of their wound and their healing environment. So we need to conduct a comprehensive initial assessment of the individual with a pressure injury, and that's recommended as a good practice statement. We need to set treatment goals consistent with the value and goals of the individual, with input from the individual's informal caregivers, and develop a treatment plan that supports these values and goals. And 10.3 outlines the need to conduct a comprehensive reassessment of the individual if the pressure injury does not show signs of healing within 2 weeks, despite appropriate local wound care, pressure redistribution and nutritional support. So the guideline, I'm pleased to say, outlines a comprehensive review of the pressure injury treatment from a wound perspective. And there is evidence and good practice statements around the following: the need to cleanse and the solutions that may be applicable to that individual and their condition, the need to debride when adequate perfusion allows, and again we need to think about the high-risk foot where there's insufficient perfusion to support good infection control, the need for best practice options for goals of care, the need to manage odour should it be a persisting problem, the need to alleviate pain, which we've discussed recently, the need to regularly reposition the person off those points, the need to select support services according to the individual's needs and what we have available and the best evidence, the need for high protein supplements to support nutritional support of healing, and when surgical review, should the wound not be responding or should it be extensive. So cleansing and debridement, the recommendations around this. They begin with avoid disturbing hard, stable, dry eschar in ischemic limbs and heels unless infection is suspected. And that's a strength of evidence, B2, with a strength of recommendation, definitely do. 12.5 outlines the need to debride the pressure injury of devitalised tissue and suspected or confirmed biofilm and perform maintenance debridement until the wound bed is free of devitalised tissue and covered with granulation tissue. So that's a B2 strength of evidence and a strength of recommendation that definitely do. There is some increasing evidence for non-contact low-frequency ultrasound as an adjunct therapy, and that's a B2 strength of evidence, but no specific recommendations were made in regard to this. As we know, we have many dressings to select from, and the good practice statement in regard to dressing selection reminds us that for all pressure injuries, we need to select the most appropriate wound dressing based on the goals of care and the self-care abilities of the individual and or their informal caregiver, and based on clinical assessment, which should include the diameter, shape and depth of the pressure injury, the need to address bacterial bioburden, the ability to keep the wound bed moist, the nature and volume of wound exudate, the condition of the tissue in the wound bed, the condition of the peri-wound skin, the presence of tunnelling and or undermining, and the presence of pain. So specifically, the guideline outlines the need to balance moisture. That is, obviously the wound is not to be too dry or not to be too wet. So the selection of dressing is based on informed clinical judgment and obviously products that you might have available in your local context. So we need to be mindful of those products that hydrate and those products that at the other end of the continuum when it comes to the amount of exudate they should absorb. Specific wound recommendations for wound care with increased strength in the 2019 edition outline cleansing, so it's now B1 strength of evidence with a strength of recommendation that to do. There's a B1 strength of evidence with a strength of recommendation definitely do for debriding devitalised tissue and biofilm. Topical antiseptics are outlined as B1 increased evidence and a strength of recommendation to do. The need to evaluate for osteomyelitis is B2 strength of evidence and strength of recommendation is a do. Non-contact low-frequency ultrasound debridement as an adjuvant therapy is outlined as B2 strength of evidence, but no specific recommendation is available. And again, that would be subject to the local context and what you have available. High frequency ultrasound at 1 megahertz as an adjunct therapy, B1 evidence and strength of recommendation, again, not specifically made. There is a B1 evidence also for the use of collagen dressings for non-healing wounds. And if this should be within your local context, there is evidence at B1, but no specific recommendation for the use of platelet-rich plasma to promote healing. What is specific and new to this guideline in regard to recommendations is that recommendations on moist gauze still ranks a B1, but with no specific recommendation and transparent films. And we need when advanced dressings are not an option. We need to be mindful that this international guideline is also relevant to countries that perhaps are not as blessed as we are when it comes to accessing products, more advanced dressings. There is B1 strength of evidence with a definitely consider or do evidence recommendation rather for polymeric dressings for non-infected category or stage 2 pressure injuries. And there is a B2 strength of evidence regarding the use of superabsorbent dressings to manage exudate. When it comes to infection and biofilm, obviously this needs to be assessed well, and that begins with diagnostic investigations, and they can be include the presence of, obviously to determine the presence of microbial burden in the pressure injury, and that may be undertaken by doing a tissue biopsy or semi-quantitative wound swab technique and microscopy. Another good practice statement has us to determine presence of biofilm in the pressure injury by tissue biopsy and high resolution microscopy. The need to identify osteomyelitis is fundamental, and we are mindful of the fact that if you can see exposed bone or probe to bone, you have a high significant risk for osteomyelitis. It's been said to be about 80% plus. So we need to evaluate the pressure injury for the presence of osteomyelitis, that is, in the presence of exposed bone, or if the bone feels rough or soft, or if the pressure injury has failed to heal with appropriate treatment. There's a good practice statement that outlines the need to have a high index, if we have a high index of suspicion of biofilm in a pressure injury in the presence of these following clinical characteristics. Number 1, the failure to heal despite appropriate antibiotic therapy. Recalcitrance to appropriate antimicrobial therapy. Delayed healing despite optimal treatment. Increased exudate. The presence of friable hypergranulation, low-level erythema and or low-level chronic inflammation, plus or minus the secondary signs of infection. So if there is the suspicion or confirmation of increased biofilm in the wound, or rather biofilm or infection in the wound, then the recommendation is that we need to use topical antiseptics in tissue appropriate strengths to control the microbial burden and to promote healing in pressure injuries that have delayed healing. There's a recommendation around the need to use systemic antibiotics to control and eradicate infection in individuals with pressure injuries and clinical evidence of systemic infection. In regard to offloading pressure and shear, we've already heard from Pam about its relevance in preventing pressure injuries, but it's a significant, obviously, topic of conversation and the need to implement good offloading strategies. So that involves, in the support services chapters, 13 recommendations for how we should best offload pressure and shear in those individuals who are seated or bedbound. And there are 14 good practice statements to support that. In addition, there are sections in the guideline that outline recommendations for surgery for those individuals where they do not respond to topical treatment and or if they should have extensive pressure injuries. There's a section on biophysical agents and recommendations. There's a section on biological agents and growth factors as well. But the part of the guideline that I think excites me the most is the section on implementing best practice, which is obviously what we all want to do. It outlines the need in recommendations and good practice statements to identify facilitators and barriers to implementing best practice. There's discussion and recommendations around quality improvement initiatives. There is discussion and around the decisive support tools that are available and recommendations. And there is the recommendations around the need to regularly monitor analyse and evaluate performance against quality indicators for pressure injury prevention and treatment. And of course, for anything to be effective, we need to audit and we need to use feedback and reminder systems. So that brings us to say, what else is new? And there are new recommendations on the importance of psychosocial support, of education, not only of patients or those we care for, but health professionals and informal caregivers, and self-care skills for patients. There's education around models, which I've just mentioned, actually around health professionals and patients, and strategies to promote implementation of best practice. This guideline is innovative in the fact that it presents 66 tables which summarise a wealth of information to assist us in implementing the guideline. There are 16 figures to provide context to evidence discussions. There are diagrams that indicate pressure points in commonly used surgical positions to remind us of the need to offload pressure, particularly in the operating room. There's updated pressure injury classification illustrations and photographs. There's discussion around mucous membrane pressure injury and illustrations and photographs. And there's inclusion of 7 commonly used pressure injury classification systems. So I would like to invite you to visit the internationalguideline.com website. This website will provide for you more information on the following, but primarily you can download today an electronic copy of the Quick Reference Guide, free. The Quick Reference Guide will summarise all of the recommendations and list them with the evidence framework at the beginning. That is the strength of evidence and the recommendation ranking. There's a detailed methodology that you can access and the paper, the reference to the paper that Emily discussed. In the early new year, there will be the evidence to decision frameworks listed on this site. And so you should be able to work your way through how the discussion, rather the evidence to the decisions made and recommendations came about. There's also discussion around future research needs, and I think this is important for people who have an interest in doing further research around pressure injuries. There will be, in coming months, companion resources developed that could help with implementation, education of both health professionals and those we care for. And importantly, we acknowledge our sponsors, and there will be other news and announcements that would be of interest to you. So that's internationalguideline.com. Taking up this opportunity, I'd also like to acknowledge with sincere thanks our sponsors that came on board for dissemination of the guideline. I need to make it very clear that during the guideline development process, right up until publication, there was no sponsorship sought for this. The costs of producing this document came for NPIAP, EPUAP, and the Pan-Pacific Pressure Injury Alliance. But we acknowledge with sincere gratitude the gold sponsors, who are Molnica and Hillrom, and our silver lever sponsors, which are Arjo, Medela, and Smith & Nephew. And we're welcome to invite others who might want to come on board and aid with dissemination and sponsorship. The dissemination will help disseminate these guidelines, again, in areas around the world where they may not be so able to access, and nor are they so financially well supported. So again, introducing the guidelines, and for those in the Pan-Pacific Pressure Injury Alliance region, I'd like to suggest to you that you can click on to this icon, guidelinesales.com, etc., or go through the International Guidelines site and be redirected. If you click on the front page, there are 3 icons. It says NPIAP, EPUAP, and PPPIA. If you're in the Asian Pacific area, click on the PPPIA icon. And with thanks and gratitude to our partners, EPUAP and NPIAP, they acknowledge that there is perhaps a lower currency conversion in our region. And so there is a special price for those people purchasing the clinical practice guidelines, which is $54.13 US plus postage, or the E version, which is $50 US, or the quick reference guide, should you want a hard copy at $30 US plus postage. So we now come to the point where we can take questions.
Great. Thanks for that, Keryln.
Oh no, this slide, sorry.
We do have some questions from the people logged into the webinar today. So I'm going to pose this one to you, Keryln. Has there been any changes to the classification system for pressure injuries in our region?
The short answer is no, and within our region the decision to remain with the classification system used in the 2009 and 2014 system still is important, and largely because the World Health Organization ICD-11 code has finally aligned itself to those definitions. So it's that staging system in the 2014 guideline that is still relevant to our area.
Thank you. Pam, I might pose this question to you. This comes from one of the listeners. What are some of the strategies for preventing heel wounds?
So I think the most important strategy is offloading, and how we do that maybe with the elevation of the limb, and some of us will have heel lift devices that we can use. Other people will just have a pillow that we can use lengthwise under the leg. So we can always also use some of the preventive dressings, but they're used in conjunction with that offloading. They're not just to be used alone. So I think they're the major
that's great. The important thing that I'm getting there is that it needs to be individualised.
Yeah.
And prophylactic dressings are an adjunct to your repositioning and your support surface and offloading. So one of the other questions here I have from one of the listeners is, I'll pose this to you, Keryln. What are your thoughts on using a subepidermal moisture device for indication of a coming pressure injury? And we might get you to discuss what the guideline has to say about, about that.
Two things. One is the guideline stipulates the need to assess moisture, and that includes the presence of edema. And that's really is important because obviously it could be an indicator of risk or developing pressure injury. And I get very excited when I see these new innovations become available that are going to be tools, I'm sure, in our hands to help in our decision making. However, in the guideline, there is no specific recommendation of a particular device. And I guess probably because there needs to be more studies around this. Remember, the guideline is evidence-based. The evidence was pulled from the quality and the amount and the rigour around studies that are available to us. And perhaps in the next guideline, there may be more evidence that allows a recommendation to be made. But at this time, it holds true that the need to assess for edema is important. And that might, as Pam mentioned, use the classic clinical tools we have at hand, which really are our hands and our eyes for good observation. Is that sufficient?
Yeah, that's great. Thank you very much. We have a question here that it appears palliative care has been missed out.
Yes, this is an area, because I work for an organisation in the community that has a large dedicated palliative care population, I am very mindful of what we broadly call lesions of end of life. And we've been personally conducting some studies around this, but, you know, it was really the fact that the evidence in the literature at the moment in regard to research is there's a deficit. This is an area where we certainly need to be conducting more studies and high quality studies to determine are the lesions that we're very familiar with that are broadly grouped as end of life, whether you use terminology such as the Kennedy terminal ulcer or the Trombley-Brennan terminal tissue injury or the scale system. The need is to assess. We are yet really, we do not have a consensus on these lesions, and as such there isn't the evidence. So it doesn't mean that these are not important or that preventing pressure injuries at end of life isn't critical. It's a given, I think. but we do need more evidence in this area. And again, I hope in the next 2024 guideline, we'll be able to say that there have been more rigorous studies conducted and we have more informed consensus on these lesions.
And I probably would like to clarify that palliative care actually is represented quite well in the guideline.
Yes.
In the implementation considerations as to what's relevant to that clinical setting and those patients. There's just no evidence-based recommendations from that clinical setting because, as you said, there's a real deficit of high-level evidence there. So people who are out there listening, this is an area that you could look at for future research, and
Yes.
We'd love to see some high-level recommendations in the 2024 guideline maybe.
Yes, indeed. Please keep the questions coming in. This is exciting.
So I have a question here for you, Keryln, again. Is there any recommendations on mucosal injuries in this guideline?
Again, this is one area where we all acknowledge that mucosal injuries are primarily device related and they are problematic. They need to be reported. But anatomically, we cannot use the skin classification system or the classification system devised for pressure injuries at stage 2, 3, 4, etc., and compare it to mucosal tissue because anatomically, physiologically, it's different. There has been some research emerging in this domain, and that's again exciting to read, but it still has a long way to go before we are able to specifically make recommendations based on strength of evidence from that literature. So again, this is an area that is in dire need of good research, and we would encourage those with an interest in this area to take up the challenge.
And once again, the resources around mucosal membranes in this guideline have been advanced from 2014. We have some photography and some lovely 3D illustrations representing mucosal membranes, and some discussion about those.
Yeah.
Although they're not within the scope of the guideline. Keryln, I might put this question to you. What is the guideline's position on the frequency of turning of individuals?
As Pam highlighted when she discussed evidence for repositioning, it has to be patient or individually specific. Now, the concept of the 2-hour turn, to best of my knowledge, has its genesis in the Nightingale era when it was if you like, a staff preference or a staff routine that dictated the fact that it would take you 2 hours to get down one side of a Nightingale ward and up the other side. And we flipped our patients like pancakes for many a year. So the concept of a 2-hourly turn is probably a starting point where we would look at how that individual skin is holding up to that amount of pressure that's been exerted in that time period. It could quite well be that we can extend it to 3 hours or 4 hours, or it could quite well be that 2 hours is insufficient for that individual. And so they would be the individual's patients that we would put on alternating or devices that actually automatically offload pressure. But again, to reiterate what Pam said, repositioning is very much a patient-specific intervention. And we need to document our rationale as to why and how often we do this.
Pam, I wonder if you'd be able to comment on medical devices and pressure injury risk.
Yes, so medical devices are often have to be quite firm on our patients and positioned well. And so when we have them, particularly on our critically ill patients, and when we put casts on, we need to protect their skin. We need to assess their skin to make sure that they can tolerate it and put the amount of padding or protection within. If it's like a CPAP mask, then we don't want to put lots of layers on, but we do want to protect the skin underneath it, and we need to make sure that the medical devices still fit well.
And I think the guideline also includes some recommendations about rotating the sort of oxygen delivery systems. That is an evidence-based recommendation in neonates. There's quite a lot of research in that area now. And there is also a good practice statement in the guideline that rotation between a mask and a nasal prong is likely to be appropriate for older children and adults as well.
Yes.
The guideline also discusses some selection of medical devices and looking at the types of material they're made of. And there's certainly been some research in that area of where facilities have done audits and found change of the device in their facility has led to a decrease in pressure injuries. So making sure you're selecting the right devices for your population. Keryln, one more question?
Yes.
This question is, does the guideline comment on medical grade sheepskins?
There is a recommendation that did not have any increase in its strength of evidence, as was in the 2014. And from memory, I think it was B2. Is that right?
I think that might be right.
B2.
But, you might need to check the grade of that recommendation
please do.
In the guideline. But there hadn't been any new research in that area. But
no.
But they are still recommended as appropriate to some individuals.
That was based on the research that was conducted some years ago. And again, we need to highlight the point that not all sheepskin is medical grade sheepskin.
A very important
and
point.
That is a really important aspect, that we need to know the product that we're using has a ranking for Australian sheepskin.
Do you have time for another one?
I think we have time for another question. One more question perhaps.
Okay, let me have a look at these ones. Right, I'll pose this one to Pam. Pam, does the use of a pressure mattress circumvent the need to turn a patient?
It's very clear in the guidelines that no, it doesn't. That we need to reposition our patient, not only because of the pressure injuries, but also for their general health. And so it definitely does not circumvent the need to reposition our patients.
Great, thank you.
Yes, good question.
There is some extra information about how you might reposition people in critical care, where it's sometimes very difficult to turn them in large ways. And the guideline talks about small shifts. But certainly we should always be turning our patients in some way and offloading pressure from different areas.
And I'd just like to add very briefly also the need to assess the heels when they are on an offloading surface, that the heel is just not going for a ride on the cell up and down, that it too has been offloaded. And the guideline offers specific recommendations to do that, as we heard, to offload the whole leg and without putting stress on the Achilles tendon or the popliteal vein. Right.
I think we're about out of time and we're out of questions.
Questions and out of time. So on behalf of Emily Haesler and Pam Mitchell and myself, Keryln Carville, we would very much like to thank, oops, take the slide. Well, we'd very much like to thank Arjo for their support, and the Australian College of Nursing again for their support in facilitating this webinar. We hope it's been useful. We apologise for our nervousness. We realise that we're clinicians, not able to present in this very intimidating sort of setting, but we have enjoyed the opportunity, and we hope that you will make the most opportunity yourself in accessing these guidelines and making the most to improve the quality of the care that we are privileged to give. So we thank you very much indeed. And again, we thank Arjo and the Australian College of Nursing. Thank you very much.